Good afternoon, everyone. My name is Nancy Knight, and I'm happy to be here with all of you to moderate with our panel of experts. This session is called Building the Future, Strengthening Community, Workforce, and Monitoring the Pulse to Predict, Prepare, and Prevent Pandemics and Address Emerging Infectious Diseases. We've seen from many of the recent global outbreaks, going back to SARS in 2003, the West Africa Ebola outbreak in 2014 to 2016, with Zika in 2015 to 2016, the COVID pandemic that lasted till 2023, and our ongoing Mpox global outbreak that started in 2022, that there have been, each of these have highlighted many of the specific strengths that we have in the individual countries and globally as a community, as well as many of the weaknesses that we have that were displayed during the responses and the preparedness for those outbreaks. Today, we're going to hear from a panel of experts about their work, their experiences that ranges from the community level and the workforce level up to the district and national levels and through some of the health systems. And we're going to hear about how that work has helped both in times between outbreaks as well as during outbreaks and threats to be better prepared for the next one. So first we will hear from Dr. Gigi Bastien. She's an assistant professor of psychiatry and behavioral sciences and the deputy director of the David Satcher Global Health Equity Institute at Morehouse School of Medicine. Then we will hear from Dr. Afam Andam, who is the Chief Medical Officer for Partners in Health in Lesotho. Next, we'll have Dr. Wilbur Lamb. He is the Professor of Pediatrics and Biomedical Engineering and Associate Dean of Innovation at Emory School of Medicine and Vice Provost for Entrepreneurship at Emory University. And we will finish with hearing from Dr. Ben Lopeman, who is Professor of Epidemiology and Director of the Emory Center for Infectious Disease Modeling and Analytics and the Training Hub at the Rollins School of Public Health, Emory University. Each will give a brief presentation that will highlight some of their work, and then we will have plenty of time for questions and answers. So as you are listening to their presentations, please get your questions at the ready, and we'll turn to you as soon as the presentations are over. So first, Dr. Bastien, let me turn to you.
Thank you, Dr. Knight, and good afternoon, everyone. It's a pleasure to be here with you all to share a bit about the work we've been leading at the Morehouse School of Medicine around a community-engaged strategy for developing a workforce to promote some of our public health and mental health promotion efforts. So I'm happy to share more about that. As Dr. Knight reminded us, we, over the most recent years, have been dealing with the most recent sort of global humanitarian emergency and the COVID pandemic that we're all too familiar with the turmoil that set in motion for the global community. Folks don't always necessarily think about what we think of as another parallel sort of pandemic that was playing out around the same time around mental health, right? And in particular, we were seeing alarming numbers of challenges around mental health for our youth and young adults here in the US, and we're hearing about similar challenges from our partners around the world. And what we quickly gathered from conversations with our immigrant and refugee communities here in the US during COVID and during our efforts to engage them in efforts to mitigate the spread of COVID was that it was important also for us to attend to the COVID-related psychosocial distress and other challenges that were emerging for those communities. And so motivated and inspired by those asks, our team set out to adapt an existing curriculum that we had for training what was originally developed to train high school students as community health workers to be responsive to the needs that we were hearing about in this time. And so the idea was really to empower young adults as agents of change that could help promote health and mental health in their communities. And so I know that my time is short. I will try to, at a high level, sort of describe the evolution of this work. So this work sits on a history of a couple decades of work that Morehouse School of Medicine has been engaged in training community health workers around the US, and it was around 2016 that the idea emerged for us to focus in on young folks, on high school students in particular, and the opportunity to engage them as partners in our public health and mental health promotion efforts. And so we launched a pilot program in 2016 that allowed us to partner with 5 area high schools in the metro Atlanta area to train an initial group of 13 high school students through a community health worker curriculum or program. Since then, we've trained hundreds of young folks through this program. We've been recognized nationally for what has been deemed really a pioneering work in this space. And so we wanted to really take that foundation and apply it to the needs that we were hearing about from our immigrant refugee populations here during COVID. A few key aspects of our approach that I'll spend time talking about is the fact that this was throughout the evolution of this work, very collaborative and community-based and participatory in how we approached it, and I'll share a bit more about what that's looked like across the life of this work. It was important for us to see our community partners as equal and substantive partners in this academic and community partnership, and you'll see that collaborative sort of approach reflected throughout. The work started initially here in Atlanta, and we started with faith-based organizations because for the local Haitian immigrant refugee community in particular, while folks will be hesitant to call a Dr. Bastian, who's a psychologist for mental health issues, they're much more inclined to call their priest, their pastor, et cetera. And so we started this work really bringing faith leaders as partners. We conducted some initial pilot work here that then set the stage for us to bring in collaborators down in Florida. Folks may be familiar that Miami also has a high concentration of folks who've come to the States from Haiti. And we've since expanded to some other areas, but the 4 sort of key components of this work were to address mental health literacy in this community, while also helping to promote COVID awareness and to address some vaccine hesitancy and problematic myths that were circulating within the community. And so we came at that through this community-based approach, aiming to create interventions that would live in the community and would hopefully be sustainable, and built in a structure for collecting data through screening in a database structure to help us track the impact of those efforts. So in terms of the evolution, although what I'm speaking about now is mostly what we've been doing over the past 2 to 3 years, really in earnest, our work with this community started back in 2016, 2017 with listening sessions. And so the community engaged sort of work is a long game space, right? And so we've been sitting with community partners since that time to understand how they talk about and understand mental health. What do they see as the priorities? What do they see as the assets in the community that can support mental wellness? What were their experiences navigating the mental health system here? So that formative work set the stage for a readiness assessment that we conducted in the second phase of this work with a couple of the churches in the Atlanta area. And then in between phase 2 and 3 is where COVID sort of entered the scene. And so we started to have more conversations with our community partners around the dual needs of COVID-related challenges as well as mental health and psychosocial distress. And so that set the stage for our adaptation work. And as that work was underway, we also developed a curriculum to train some of our health professional students at the Morehouse School of Medicine, so our medical students, our physician's assistants programs, and some of our public health students to think about bringing a trauma-informed lens to their efforts to engage Haitian migrant and refugee communities in our health promotion initiatives. So to give you a quick sense of what the program entails, they start off with an online curriculum that lives on Canva, that learning platform. It's comprised of 20 modules that covers everything from what is a community health worker, what are some important chronic illnesses to be aware of. There's a robust kind of mental health component that introduces them to depression, anxiety, substance use. How do you identify these things? Helps them to think about engaging community. How do you go about interacting with community to work collaboratively on health initiatives and projects? And then they take that foundation of the online curriculum and apply it towards developing community projects that are created in collaboration with our community organizational partners. I mentioned earlier that there's a robust kind of data collection and health monitoring component. Each trainee receives a tablet, and they are trained to gather some information from the community. They're given a blood pressure cuff to take blood pressure readings, to screen for depression with the CUGH2025 screener, for example. And so all of that information is uploaded into a database. And in addition to the training experience and a certificate that they get, they receive a $1,000 stipend, which is always the main thing my young folks want to hear about before we go any further about what they'll be up to. And so, as I mentioned, we initially started this work in Atlanta, then brought in partners from Miami. We've since received some additional funding to expand to Boston and New York as additional sites, and so we're excited to now have trained young folks in all those sites that have high concentrations of Haitian immigrant and refugee populations that they're equipped to support. This work is a work in progress, but I want to share a bit about what we've been able to do so far. We've successfully trained 50 young adults in the initial 2-site phase of the work. Currently in the 4-site expansion, we have 40 trainees who will be wrapping up the program in May of this year. And through our assessments and pre and post evaluations, we've seen improvements in everything from COVID, awareness and understanding, mental health literacy, well-being as measured by screeners like the PCL5 for trauma, the PHQ-9 for depression, and et cetera, to really help us get a sense of not only what impacts this is driving for the communities that are beneficiaries of community programs, but for the trainees themselves in terms of their own well-being and functioning. We're excited that this has been, a realization of our efforts to create a pipeline, as a lot of our trainees have decided to continue in health fields. Some are seeking coming into Morehouse as medical students, as public health students. We build in a component of this project that pairs them with mentors if they're interested in continuing in these areas. And we're excited about the opportunity to be equipping these young folks to really be effective partners in promoting wellness in their communities. There's been a range of dissemination efforts like this, and I'm most proud of the fact that even those activities are very much collaborative. So you see the 2 pictures there from a conference that was actually held in Port-au-Prince, Haiti, right before COVID. It was a spirituality and mental health conference, and I'm in the picture at the bottom, but up top is Father Carl Jean, who's here in Atlanta, who joined us in talking about our community and academic partnership and how it's driving wellness in our communities. And our hope is to continue with dissemination, and we've submitted our first manuscript on this work and are working to secure additional funding. Our learning is ongoing in this process, but I think it's reinforced what we understand and know well at Morehouse, which is that community-engaged work is really central to tackling complex issues within our communities. We know that community and academic partnerships are a bit messy at times and can be dynamic, but they've proven to be absolutely worth the effort of taking those on. Culturally and contextually tailored methods we think are particularly essential and needed, and this work has allowed us to really flesh that out for this unique and underserved population. And the idea of engaging young people is what's been most exciting about this, and to see them really take this up and to see themselves as leaders and bringing about solutions in their communities is exciting. And it, for us, reinforces this idea that while we as health and public health experts may have the right message, resources, et cetera, we're not always the best messenger. So what we're learning is that when we take right message, add to it the right messenger, it can truly be an impact magnifier. And so I'll stop there. I know my time went really fast, and pass it to the next.
Thank you so much, Dr. Bastian, for your presentation on the community-based work that you've been doing with hard-to-reach immigrant and refugee populations here in the United States. Next, I'll go ahead and turn over to Dr. Andam. We're going to hear from him about some of the health systems work with workforce and broader health systems that he's been involved in Lesotho.
Thank you so much. Good afternoon, everyone. It's a pleasure to be here, and my name is Afam Andom. I'm working as a Chief Medical Officer for PAH Lesotho. I'm going to share with you some of the PAH model of care of accompaniment to strengthening the national health system of Lesotho. So it's not okay. Oh, the big one. Okay, great. So Partners in Health started to support the Ministry of Health of Lesotho starting 2006. Primarily, the invitation from the Ministry of Health was to support in HIV in responding HIV program. But Partners in Health, we realized that supporting only HIV program, you cannot address or improve the HIV program by itself. So quickly we tried to work on strengthening the primary healthcare service delivery, comprehensive primary healthcare services in a very hard remote area. And we have been investing in what we call 5S models that I will mention it later. So, and then the effort of our investment was highly recognized by the Ministry of Health. And then the Ministry of Health advised approach Partners in Health to scale it up to a national level. And we started to implement it in a pilot phase of 2. That's called the National Health Reform Program Model of Care. This is to build a resilient health system in Lesotho. The approach was in 3 areas. One is primarily service delivery strategy to achieve universal health coverage. Second is strengthening health system management. Third is professionalized village health worker program. We call it village health worker program in Lesotho. It is community healthcare workers. So the first is service delivery strategy is basically we first assess the burden of disease based on incidence and prevalence that we have, and also map up a target to achieve the needed response, and also align the input that is needed in terms of, it could be staff, it could be supplies and infrastructures. And the second area is strengthening the health system management. We restructure the district health management teams and also devolve the resource allocation and also decision making from the central ministry to the district health management team. We continuously engage in training capacity building programs on how the district health management team to develop planning, budgeting on their own at their respective districts, because the context differ from district to another district. And also we deploy a technical team work to accompany them at the district level, and also we deploy technical people at the National Ministry of Health level. And the third pillar is to restructure the village healthcare worker program, and this is to expand their scope and also with clear roles and responsibilities. The outcome is to increase demand, improve access, and improve quality of services, and improve linkage of services from community to health facility, district, and the national tertiary levels. So this slide is one of the examples that our approach. We use the estimation of the disease burden. That's one of the approach for TB programs that we are doing currently now. Firstly, we estimate based on the incidence and the prevalence, what is in the catchment population, and also then what do we need, how many people we need to screen to get the yield that we want to intend to achieve. And then, for example, in this case, to screen, we serve 7 clinics in very remote areas and around 89 population. And also to screen that, we anticipate that based on the TB, the data that we have in a year, 590, we estimated. To get that, what kind of tests do we need? What human resources do we need to achieve this target? And we use we call it the Partners in Health as 5 model of care system strengthening approach. The first is the staff. What staff do we need to address? We need to have qualified, enough quantity, and well-trained staff. And also the second is the staff. What equipments or what tools do we need in place to address the challenge that we have in the health system? The third one is the space. We need to have safe space where it can serve for the management and treatment of patients that we have. And the third is the systems in the terms of the leadership, governance, and information and financing. What kinds of systems we need to put in place to monitor and track the strategies that we put in place. And the third one is the social support, availability of basic necessities, provision to patients, because treating alone it might not serve. If one patient with diabetic and then he doesn't have food to eat or place to stay, treating, and then he will come back with another complication. And then I will give you a few examples of what we have done. And then Partners in Health also have been supporting the Ministry of Health in the response of multi-drug resistant TB since 2007. And we have been really struggling to address this high MDR TB case because we receive at the national level, it's tertiary treatment center. Because of several socioeconomic factors, patients, they come very late and hard to address even, especially during the COVID-19, because the system was not well prepared, and we will really struggle where to admit those patients who need a ventilator, because there was only one tertiary hospital with only 8 beds. So Partners in Health come up with a strategy. We need to build a separate dedicated ICU and high dependency unit for the MDR-TB patients. And we have seen, as you can see in the graph, a significant mortality reduction from the time that we started. As you see in the photo, the minister, while visiting the facility. And the third area that in responding to COVID-19, to strengthen the national medical oxygen ecosystem to respond to the pandemic. Lesotho during COVID-19 pandemic was relying in South Africa to import oxygen. South Africa was highly affected with COVID-19, as some of my recall, and it was really for us a challenge to get oxygen, and we were really stuck. And Partners in Health come up with a strategy to establish a PSA plant and also train the healthcare workers on how to maintain and also distribute oxygens to different health facilities in the country. And not only through this, and we realize that we have also, following the PAH establishment of PSA plant, there were so many other PSA plants through Global Fund and others, but there was no maintenance place. And then we realized that we established Biomed team, and we established Biomed Center of Excellency. And even we went beyond the COVID-19 response. We now established Biomed Center of Excellence, whereby any medical equipments we fix it and we calibrate and also send back to whatever districts that we have. We trained all the Biomed engineers in the country, and also we developed a supervision mechanism So this is, in short, what I want to share with you, the PAH approach of model to combine the Ministry of Health. Maybe I can end with the last quote of our beloved Pofama. The idea that some lives matter less is the root of all that's wrong with this world. So I will end, maybe we'll enrich in the discussion. Thank you so much.
Thank you so much for sharing your approach with the 5 S's and the impact that that's had with ongoing challenges like multi-drug resistant tuberculosis, as well as the urgent challenge of COVID and oxygen need. Next, I'm going to turn to Dr. Lamb, and he's going to talk about some of that stuff, the diagnostics that are needed out of the 5 S's. So Dr. Lamb, over to you.
Thank you. Thank you for having me. So what I'll spend the next few minutes really talking about is when a public health crisis occurs, when you have the government and multiple agencies working together with academia and the private sector, things can move really quickly. And this is a great example of one of those incidents when everything works. So this really stems from our work as a diagnostic center that is funded by the National Institute for Bioengineering and Bioimaging. So NIBIB of the NIH funds a point-of-care technologies research network, of which our center is called the Atlanta Center for Microsystems Engineered Point-of-Care Technologies, ACME, POCT, really ACME for short, because all those words are really way too long. Doesn't sound too good rolling off the tongue. So we in ACME, our charge within the entire network has always been about technology. So you see multiple other centers, throughout the United States. And we were set up around 2018, and we've been doing this type of work. We're trying to foster the development of new point-of-care diagnostics, really, frankly, for multiple diseases. But then this came, right? And then we were asked to pivot. And we were asked to help out with this global pandemic. So you all remember, these types of scenes and so forth. So the NIH actually asked us, could we take advantage of this? We, as the technology center that is part of POCTER and part of the Point of Care Technologies Network, we're going to be part of a bigger initiative here. And the initiative here in the United States, from the very top, was called the RADx initiative, so the Rapid Acceleration for Diagnostics. So what happened here was that the entire federal government was basically turned into almost like a VC, a venture capital firm, where the goal was to identify which diagnostic tests worked for a brand new disease, right? And figure out which of these tests we would then scale up and make available to the American public ASAP. So in general, when you invent a diagnostic device, the amount of time it takes from invention to implementation in the market is on average 10 to 15 years. So the goal here was to shrink it down to 1 to 2 years, right? And frankly, we did it. So how did we do it? It was a big effort, and we, again, worked very much like a venture capital, where we said, okay, there's going to be a bunch of tests in the beginning, we're going to whittle it down, whittle it down, whittle it down. So the NIH looked to us in Atlanta and said, you guys at ACME, since you're technology focused, you will be our eyes and hands. You will be the verification center for all COVID-19 tests moving forward. So how did we do this? So we set up multiple infrastructures. We, in Atlanta, were one of the first groups actually to start collecting samples like crazy. We swabbed everybody. I mean, I myself probably got swabbed like 5 or 6 times. Biobanking, we discovered, was so important, right? Because whenever you had a good biobank, you could then, whenever a new test came, you can then just dig stuff out of the freezer and work. But that wasn't enough. We also wanted live virus, so therefore we had our biosafety level 3 infrastructures constantly busy. So whenever a new test came, we would grow live virus, and then we'd be able to actually have samples of different levels of virus so that we can get what's called the limit of detection with these new diagnostic tests. And also our group is comprised of several institutions, not just Emory University here, but also Children's Healthcare of Atlanta and the Georgia Institute for Technology, Georgia Tech. There we actually found out that we could do quite a bit of work in terms of manufacturability, human factors. It's one thing if the test works, but if it's meant to be used at home and it's really complex, well, it's not really useful then, right? We need it to be simple to use so that the average person with just a grade school education would be able to use it. We saw a lot of cases in which the technology worked really, really well, but it was so hard to use, it was basically rendered non-viable. So every single test, came through us first. So we helped a lot of these companies get their emergency use authorizations. So it was a collaboration between us, between the NIH, of course, FDA, and CDC. It was truly, truly an interagency collaboration. And we saw these tests come to market within a year and a half. So it really is, I can't tell you how fast that is. And the impact was pretty big. So, okay, real quick, show of hands, all of you, at least from the United States, who's used a COVID-19 test? Yeah. You're welcome. Yeah. And then in 2022, we needed to pivot, right? They said, okay, other things are coming. And so they said, you guys, our test verification center, let's pivot. Let's go to another disease. And that's exactly what we did. We would collect lesions from patients that were suspected of having Mpox. And again, interagency collaboration. All these agencies from the federal government work together to get us samples. We would use our own patients. And again, very quickly, within a span of 7 months, right, we set up a program in collaboration with the NIH, with the FDA. Within 7 months, we actually got a emergency use authorization for a point-of-care test. That's unbelievable. So I've created a few companies for my lab too, and the average time it takes something to get approved at FDA is way longer than 7 months. But since we were collaborating with them, they would actually look at our data. And through that, we were able to really, really shrink down the timeline. So, really our lessons learned here is that, yes, interagency collaboration, especially if the private sector and academia are really working tightly together, really fast, amazing things can happen. So here's just a quick summary of everything that we've done and what we are doing. So we have seen many, many, many tests, right? Verification of technologies is so important because it also allows for what's called fast failure. You want to figure out which ones work, which ones don't work really quickly so that you can devote the resources to the ones that are floating to the top. So we're now applying this to multiple diseases. Dr. Francis Collins, who was the head of our NIH, when he stepped down as the NIH director and started working for President Biden, his initiative was to eradicate hepatitis C. So we helped them get a emergency use authorization for a point-of-care hepatitis C test. We didn't invent it. We helped the company that invented it move forward and get authorization, again, in collaboration with FDA. We're now doing this for HIV in terms of point-of-care viral load testing. There was a whole maternal health technologies initiative that we started. So we're starting to get pretty nimble because you could ask, with maternal health, are you talking about like a blood test for preeclampsia? Are you talking about blood pressure monitoring? So all of the above. So we are setting up all these different infrastructures to do that. And we continue to do this work. And could not be done without, even within our own universities, multiple people, all with different domain expertise. And I think from there, I will stop there, and I'll just kind of fast forward all of this through these slides, which, sorry, go back. Thank you. Thank you.
Thank you so much for sharing that extremely exciting work, the behind the scenes of what has been happening with diagnostics that then we all see on the shelves. So thank you so much for that. Next, I'm going to turn to Dr. Lopman. So we've talked about work that happens at the community level, the interventions and the data that's gathered at the community level. We've talked about the broader healthcare systems and public health system and the interventions that happen there, including the really important work of diagnostics. Dr. Lopman's going to talk about how do we use some of that data? How do we look at modeling and analytics to help us to be able to determine what's most effective and what might be happening with that next threat that we're facing. Thank you.
Great. Thank you so much for the introduction and the segue. Thanks, everyone, for joining us this afternoon. As was noted, what I want to talk about is kind of how the work that we're doing at Emory and within our larger community, kind of bringing analytical epidemiology to answer questions relevant to pandemic response, which involves both technical kind of development as well as building kind of workforce, so the training to have this kind of community that's ready to respond to outbreaks and pandemics. So I'm going to talk about this large national network that was established in 2023 through an investment from the CDC. So in 2022, during the pandemic, the Center for Forecasting and Outbreak Analytics was established at CDC. Essentially, this is a modeling group at the CDC, and they were stood up to answer these sort of fundamental questions that were arising during the pandemic. Things about how large is the outbreak going to be, forecasting a few weeks or months forward, asking kind of scenario kinds of modeling questions like, who should be targeted initially with vaccines, et cetera. So this center was established at CDC, and they, in subsequent year, in 2023, funded a large national network called InsightNet. It was a really substantial investment. Many of us think it was long overdue. Considering all of the work of DOGE, the Department of Government Efficiency, I won't tell you quite how large of an investment it was, but it was really, really substantial. 13 centers around the country were funded. And the grand vision of InsightNet is to develop this kind of modeling capacity infrastructure around the country. And the grand vision, the long term, is to have something like a national weather service, a weather forecasting service for infectious diseases, pandemic threats, et cetera. So we were one of the 13 centers that were funded in 2023. And there are three types of centers that were established: centers for innovation, centers for integration, and implementation. And the idea here being that we need to innovate kind of methodologically as well as training the workforce. And we also have to work out how to test out these methods, analogous to what we heard about testing out diagnostics, testing out analytical epidemiological methods in the real world, and then figuring out how to scale those up. So going from innovation to integration and finally implementation. So implementation is the kind of weather forecasting service, which we're still many years, if not a decade or so, away from, for both the technical as well as the kind of infrastructure reasons. We're one of these centers at Emory. We're the Emory Center for Infectious Disease Modeling and Training Hub, or CIDMATH. We are one of a Center for Innovation, so kind of on the early end of the pipeline. And our mission is to develop a pipeline of new analytical methods, tools, and platforms for modeling efforts. And this is the important part, all in the service, all ultimately to inform public health decision makers, right? I noted already this is a major investment. This is a 5-year cooperative agreement from CDC. At Emory, it's a wide cross-campus initiative. The kind of home of the initiative is at the School of Public Health, where I sit. But it really spans across campus, including people from College of Arts and Sciences, biologists, computer scientists, and also School of Medicine. We're also closely partnering in Georgia with the Department of Public Health, the Georgia DPH, as well as another community partner, Kaiser Permanente, Georgia. We're implementing studies and projects. So we're innovating in sort of technical areas because I think these things are important to kind of keep developing. So things like improving wastewater analytics. This is obviously a very exciting area, and also particularly important because of the kind of work that Dr. Lamb just introduced, with less diagnostic testing done in clinics and public health facilities. We are losing one of our traditional surveillance streams, and so wastewater can supplement that. Other areas of innovation include using machine learning for both short-term forecasting as well as longer-term scenario modeling. We're collecting better data on the kind of human behavioral aspects of infectious disease transmission, something that, of course, that changed and evolved a lot during the pandemic, but for which we actually have quite limited and poor data on. And finally, one of the kind of bread and butter activities of epidemiology and public health is vaccine evaluation. So those are the kind of technical areas that our center is innovating. But as I noted, an important part of this is also developing kind of the human resources and capacity. One area that the center is engaged with is this major training institute called the Summer Institute for Statistics and Modeling Infectious Diseases, or SISMID. SISMID actually has been run for 15 years in the University of Washington, and it moved to Emory in its new permanent home as part of CIDMATH, our new center, I'm the co-director along with Dr. Natalie Dean, whose picture is shown here. And CISMID is really this venue for providing really advanced training in infectious disease, in outbreak analytics and modeling. About 250 students attended last year. About 35 of those were international. And if any of you all are interested in finding out more what modules are offered, I would encourage you. Sorry, I forgot to put up a QR code, but you can Google CISMID and see what offerings we have this coming summer at Emory. So my last couple of minutes, I want to reflect on kind of some of the gaps, not just in the US, but also globally. And I think there are real analogies for what we're doing and kind of some of the global gaps in outbreak analytics, infectious disease, epidemiology, and modeling. One is pretty obvious that modeling institutions are really concentrated in Europe and in the US. I actually did all my postgraduate training in the UK, where there's this very deep tradition of analytical epidemiology that is really central to public health decision making. For example, vaccine introduction, vaccine strategy. We are behind in the US, but as I mentioned, as we've been talking about so far, we are catching up by developing these agencies at CDC as well as this national network, InsightNet. Part of the reason underlying this is that these technical skills and the unique things about infectious disease epidemiology are actually not part of the core curriculum in public health and even epidemiological training. They're specialized tools. They're not mysterious, but they're not really included in the core curriculums yet. And so because of this, and that's true in the US as well as in global kind of public health training, because of this, we're kind of lacking the local, national, and regional networks that are required to sustain this kind of knowledge. So there's this kind of yawning gap between the technical modelers who are relying on basic public health infrastructure and data to do the analytical work and then communicate it to policymakers who also kind of don't have the language or the understanding of what can and can't be addressed through kind of analytical epidemiology and modeling. We've been making some efforts from our group to, along these lines. We hosted a workshop just last month in India, in Mumbai. There's a national group in India called the National Disease Modeling Consortium. We hosted a workshop, participated in a workshop of about 30 people from around the country, which included policymakers, as well as public health workers, and modelers. And the specific topic of this workshop was about modeling public health impact of new enteric and respiratory vaccines. There are some global courses. This is one that I'm not at all involved with, but wanted to note that there is training going on globally. This is a long-standing course hosted in Cape Town, South Africa. And I'm really pleased to see that there is now a recognition that there is this gap globally. CEPI, the multinational organization that was behind the COVAX initiative to promote the implementation of COVID vaccines globally, recently had a call for proposals about implementing partners for Global South leaders in epidemic analytics and response networks. So a kind of recognition that if you want to be able to answer questions like what vaccine do we need, what vaccine strategy is most appropriate, which group should be targeted, you need to develop this capacity. So really delighted to see that this group has kind of recognized this need and is going to be funding some of this work going forward. So I'll finish there. Thank you very much for your attention and looking forward to our discussion.
Thank you so much. I think we'll go ahead now and start with some questions. And I don't know if we can adjust the lights a little bit so we can see the audience a little bit better. There are 3 microphones in each of the aisles here. So I'll let you all get your questions ready and start coming up to the microphones. And in the meantime, I'm going to go ahead and ask a question to our panel members. I'm going to start with something really simple like sustainability. Everything that you've touched on is a critical component of the pandemic preparedness and response architecture, from the community level to the health systems level to the ability to predict and forecast with accuracy. All of this requires resources. It requires human resources. It requires financial resources, and we know that resources are not unlimited. So tell us a little bit about what you've learned and in how to help the work that you're doing to be more sustainable into the future. And I'll just open this up to all of you.
Happy to kick us off. That's an excellent question, and I think it's one of the major challenges that we encounter with so much of what we do, but I think especially in community, because often our community partners are sensitive to the experience of having had folks come in from different institutions or different organizations to engage them in initiatives that evaporate really quickly, and so it's something we are constantly striving to be more sensitive to. I think the fact that our community engaged strategy really begins from the outset, right? The fact that the initiative I spoke about started with listening sessions with community where they articulated the thing that we ended up touching as pain points, as areas that they need, helped us to get the initial sort of hook and buy-in that spares us a lot of the coming on board and understanding the why and the importance, which I think is really key to sustainability, when you can get on the same page into some shared understanding with a community about what the issue is. I think that helps to set the stage for figuring out together how do we then tackle that. And I think the strategy of working to cultivate talent within the community that doesn't sit inside of our teams at Morehouse School of Medicine, but that these young folks are already embedded in their schools and in the churches and the communities has really helped them to think in ways that we might not have, right? We have our own ideas about how we could have packaged some of the information that we wanted to share in terms of understanding COVID, understanding what the challenges were around mental health, but it took the community to say to us, well, actually, a lot of our folks see radio as a key sort of medium for gathering their information, or are communicating a lot on WhatsApp about what's going on with COVID, and so how do we create things that are quickly shareable on WhatsApp? And for our young folks, how do we come up with a TikTok campaign where you can talk to your peers about stress and anxiety that's coming up? And so our experience has been that when community is brought on board as early on in the process as possible, that helps to get the buy-in, and when we bring to bear our part in terms of equipping our community partners with tools, helping them to see how a research sort of structure can help them to be systematic about what they can identify as challenges and what they can apply to that and what the impact is of those efforts, that is where we've seen some success with that. So one example might be, as a part of this project, last year, one of our young folks identified that there was a need to do some work with women in the community around creating spaces for self-care and thinking about their own needs in terms of mental wellness. And so we found some funders to support a kind of weekend-long wellness retreat, partnering with one of the local churches. And the thing that we experience often is that funding wraps up for our initiatives, but actually this year, that church that we partnered with has taken it up, and members of the community, we had 35 women participate in this retreat, saw the value in that first version that they were a part of for free because we had grant funding for it last year, and so they were able to convince their peers to be willing to pay $50-some a piece to be a part of this. And so they've now taken ownership of sustaining that because they saw firsthand what the value is, and they saw it as responsive to needs they'd articulated.
So very exciting. Thank you.
Great. Thank you so much. I think that's a very important question. We, as partners in health, we have been developing model of accompaniment to the Minister of Health. So whatever intervention we do it together with the Minister of Health. And then when a new improvement came, we support the Minister of Health to develop policies and strategies so that it can become a national program. So I think that helps us to sustain most of the interventions that we have been doing to support the Ministry of Health. I can give several examples, but For example, the village healthcare workers, they were not, they were volunteers. They were not getting anything, but since Partners in Health started to support the Ministry of Health, we tried to hire them and also pay them regular incentives. And then we support the Ministry of Health to develop the National Village Health Worker Policy document. It went to the Parliament approved it, and now it is village health workers are the member of the main workforce stream. So we work together and we replicate whatever achievements that we want. Thank you.
Great, thank you. That's also very exciting. Getting parliamentary change is no simple feat, so congratulations on that.
Yeah, so regarding sustainability, and one thing that our center has discovered is that working with industry is part of that. So everything that we've done, for example, for the RADx program, we've had other industry partners come up and say, oh, what you're doing there, we actually find value in you telling us, for example, if it's an investment group, whether a test works before we want to invest money in it. And sometimes even the diagnostic developers themselves, they want access to our samples and so forth. So we're starting to develop some models that we can use those work that we do with industry to kind of, feed the more academic work and also foundations. We've learned that they have very specific disease interests, and sometimes there's a diagnostic test they might be interested in funding. They send it to us first to again, vet the project. Yeah.
Thanks. He has a very important role for our private sector. Dr. Loman.
Yeah, so in a slightly different domain about kind of outbreak response and modeling work. I mentioned this national network that's been recently established, and I think one of the really wise things that was made part of the network was a requirement for all of the centers around the country, academic centers, to have a state or local implementing partner. So I mentioned in Georgia, at Emory, our partner is the Georgia Department of Public Health, and all the other 13 centers around the country have this. I think this is really important for sustainability, for impact. Traditionally, in many places, modeling advanced analytics has been nerds talking to other nerds, academics publishing in journals that each other reads. But if we really want to address real public health questions, it involves knowing what those real questions are, as well as having the interaction with, implementing partners and policymakers. And so I think that's the wisdom of having these academics interacting with, in this case, state and local public health partners. And I think there's many examples of this, but if I think back to the pandemic, one question from early on when vaccines were, when there was a scarcity of vaccines was, how to distribute vaccines. Vaccines were trialed as 2-dose vaccines. There was a real question early in the pandemic, should we give twice as many people a single dose, or should we stick to the schedules? And this is a kind of question that can be addressed by a real public health question that can be addressed by modeling, but only really happens with the interaction of the technical folks with policy makers.
Yeah, great example. Thank you so much. I see we've got a few people up at the microphone, so let's go ahead and start over here. Maybe if you could just tell us your name and where you're from, and then ask your question. Thanks.
Thanks. I'm Chris Olson from the University of Wisconsin-Madison. And my question is for Dr. Lamb. I'm wondering if you can talk about what may be happening in terms of either clinical point of care or even eventually at-home diagnostics for H5 influenza.
Yeah, it's a good question. In fact, we have an initiative right now with the NIH looking at bird flu. And one question is whether the existing flu tests, which are now going on the market, right? And we helped with that as well. There's these combination tests now, at least here in the US, where it's both COVID and influenza. And question number one is whether those tests actually work for bird flu. Preliminary, spoiler alert, so far so good, right? it's still very preliminary. But then the next step is, well, we want to differentiate, right? So there are developers that are developing antibodies, and we're trying to assess that. So ongoing, but more to come.
Great, thank you. Let's go to the center here.
Hello, and thank you to all the speakers today. My name is Camille Grippin. I'm a doctoral student at Indiana University, and I'm also a global health worker, mainly in Latin America and the Caribbean. And my question is for Dr. Lopman. I don't know if you could speak a little bit about the infodemics surveillance system. So one of the things as public health workers during the pandemic that we were not prepared for was to deal with misinformation through Facebook, through WhatsApp. There was just a lot that we were combating in parallel to the response. So I don't know if you could speak a little bit to that, if you can.
Yeah, sure. Thanks for your question, and it's maybe it's the most important thing kind of going forward is thinking about disinformation, misinformation, and how people are kind of how that information is spreading, how people are using it, and how it's changing behavior. It's not really my area of expertise. There is some work being done in our center, so I won't go into kind of any depth, but I think there's a lot of interesting, important work going on of figuring out like how to listen in to just social media or other kind of digital sources to kind of see which information is spreading and which networks it's spreading. But then I think really crucially, and this is where like we have to link between the sort of digital sources, which are incredibly powerful, to what's really happening is we still need to really measure human behavior, how people are actually changing their behavior in response to information that's out there. Of course, during the pandemic, we saw a lot of risky behavior driven by misinformation. But I also reflect on the fact that with all this misinformation out there about vaccines and a vaccine skeptic, quote unquote, in the directing HHS now, 92% of children are still receiving, all the pediatric immunizations. And so I think my point there is that, the importance of linking the information environment that we're in and how influential it can be, but really measuring kind of outcomes and behaviors as well. And so I would advocate for this, not giving up on kind of classical epidemiology and classical data collection in addition to monitoring kind of infodemics. Thanks.
I think one piece that I would add to that, because I think this is the misinformation, disinformation issues, a thing that we not only saw with COVID here, but as I think about work that I've done around other sort of disasters, whether it was post-Ebola work in West Africa or in other settings, we've had to similarly think about this issue of a messenger sort of message, right? And so that I think is where we've found some success in helping to ensure that those trusted leaders and credible voices in community are equipped with the right information. If I think about what we saw in Liberia and Sierra Leone around the spread of Ebola, it really is, and as I did work spending a year there as a Fogarty Fellow, sitting with communities, what I learned was that when it was the imams and the pastors and stuff who were helping people to understand why they couldn't congregate and come together for services, that is really where they started to make the shift. And so I think that notion of us understanding where our roles are, where we fall back and where we tag in our other partners, and really building coalitions to get across the information that we need. That's been my experience both abroad and here in the US. Here in Clarkston, here in the area of Georgia, they actually had one of the best levels of uptake of vaccines initially, and some of that was around targeted work with faith leaders and other folks who work with those immigrant and refugee communities around messaging and how they bring together folks for community leaders to be the ones sharing and moving that information forward. So I think this issue of right message and right messenger is an important one in these situations.
Yeah, thank you both. It's definitely a really close connection between the analytics of what are the messages that are going to be most effective, but the on the ground, right at the individual and community level application of those messages and in a way that's heard and trusted. Let's go back over to this microphone.
Hello, Ken Kessler from Rosalind Franklin University of Medicine and Science in Illinois. This is directed mainly to Dr. Bastian. Could you speak a little bit about your program's follow-up when the community health workers screen for the behavioral health issues that you're doing? What do you do next then? Because one of the things we found in my region is the services are very limited, and we can identify these people, and then we don't have anywhere to send them, and then we have a kind of a disaster on our hands. So I was wondering if you could share a few thoughts on what's going on in your community to provide some resources once you've identified these people. Thank you.
Thank you for the question. It's an important challenge, right? When we start asking what's the issue, what are we going to do with what comes out of those conversations? And so what we've learned, I'd say, would be two things. I think the strategy of training this community cadre of folks who are positioned to at least do some community level initiatives around sort of awareness campaigns, education campaigns, has in itself yielded some positive impacts as people come to understand more the nature of what they might experience around a crisis or something like that. What do we expect in the way of stress and so on. So that, I think, has had its own sort of calming effect that we hear about from our partners, like our faith-based folks who would initially talk to us about being inundated with needs and asks from the community will say, after you all did this session and explained that these kinds of things are normal, we get less of those calls. The other strategy, though, has been to really bring together in a centralized space what resources, and admittedly they are limited, might be of interest and appropriate for our community. And so one of the partner organizations, for example, in Miami, has developed a directory on their organizational site, which helps folks to identify Haitian mental health providers or providers who have experience working with Haitian populations across the US. And so similar to APA's, sort of the American Psychological Association's directory for finding a therapist in your area by zip code, you can go to this directory and find folks. Now, admittedly, if you do a search in Atlanta, you'll find like 2 providers in that list. But it gives people a starting point if they're at that point of readiness to engage a formal health system. And so that's been one of the strategies. And also, I think, helping to find ways to create solutions at a population and community level, as we've listened to what people have shared with us about either negative experiences they've had going the more traditional one-on-one therapy route for some of their mental health needs, or their hesitation to engage that system. We've been pushed more towards thinking about community level, which is why things like the Women's Weekend Retreat happen, where we tracked pre to post, what were they endorsing in terms of stress and those kinds of things. So I think it's creating opportunities for us to think about more of those group population level offerings. I can tell you that the one cohort of those young folks started a Saturday morning radio talk program that's where each weekend they talk about a particular topic in mental health and open the lines for people to ask questions. And it's been fascinating to me to see what comes out of that and the cross-generational sort of engagement of folks of my parents' generation wanting to know more about depression and anxiety and what that can look like. And so it's an ongoing sort of challenge for us to face, but I think the combination of having those young folks who are already embedded in community, who know their peers, thinking about creative avenues for engaging this community while also making them aware of the formal sort of pathways for care if they're interested and ready for that is what our approach has been thus far. But we have work to do in building a workforce that can meet the need is the truth.
Thanks. Let's go to the center.
Yeah, Quentin Eichbaum, Vanderbilt. My question is to Dr. Lockman and Dr. Lamb. I've been involved a lot in low and middle income countries in Africa in mapping the laboratory strengths and pathology diagnostic capacities in those countries, and the picture's not a very pretty one. Many countries have no pathologists, some have one, some have none. The labs are not in a good status. We've mapped Mozambique and Kenya and Zambia and Nigeria, and we're going through the continent just trying to see what the status of the labs is. So what I'm very concerned about, and I'm curious about your perspective, is in terms of pandemic surveillance in those countries, the status of the labs and the diagnostic capacity. And the Maputo Declaration of 2008, where Deborah Birx was there and Eric Gooseby, and they drew attention to that in the setting of PEPFAR, and we kind of revisited it at an AfriHealth meeting in 2018. But it is something of concern to me about what can be done about it, and if you think they're sufficiently strong to have sufficient diagnostic capacity and pandemic surveillance. But then my question pivots to Dr. Lamb. Do you think point-of-care testing could fill that kind of gap to some extent? Are we reaching that kind of domain in the availability of different point-of-care tests to in some way substitute or fill some of those gaps at all?
Yeah, great question, and I think I share similar concerns as you. But I do see personally, in my opinion, a path forward. A lot of the diagnostic tests, technologically, antibody tests and so forth, the science has been worked out, right? So where a lot of the innovation now is really about making them cheaper and more robust, and then starting to connect them with information systems, right? So one thing we've been discovering is, for example, smartphone technologies are getting cheaper, and one interesting link is that even in low resource settings, even though the medical infrastructure may be poor, the telecommunications infrastructure, on the other hand, is actually sometimes better. Like my phone actually works better in some countries than for example, in Northern California, right, where Apple is. So we're trying to leverage that, and yes, there's many challenges there as well, right, in terms of connectivity and so forth. But I do see that as one potential path forward. So a lot of the innovation in terms of the technology developments is actually making it cheaper, making it more robust, rather than trying to increase the sensitivity. And I think that's another thing we've learned too during the pandemic, is that if you want a test that is extremely accurate and extremely precise, in contrast to maybe a test that maybe isn't as sensitive but more easily accessible, there's actually value in both, because from a public health perspective, maybe you don't need the most sensitive, most high-tech test, but if you can broadly disseminate this one that's maybe not as quote-unquote good, but is broadly accessible, there's value there. So we've learned about that, and it doesn't have to be perfect for it to serve, for it to be functional. And as long as you can connect it with the information technologies, and I guess maybe I'll lead you to transition there.
Yeah, thanks. I agree with all of that. Basic diagnostics is really the data stream. That's the core of epidemiology and program evaluation, kind of analytical evaluation. I think back to, I spent many years at CDC before I moved to Emory, and did a lot of work on the global evaluation of rotavirus vaccines. And this is a case where we had that diagnostic, this simple and highly sensitive and specific diagnostic. It was an ELISA test. And this, having a straightforward diagnostics that could be used essentially in many environments, kind of lower capacity environments, technical capacity, meant that we could evaluate these vaccines. We could look at both in terms of like effectiveness, but also over time, and looking at the impact of the vaccine in reducing hospitalizations, for example. And you contrast that to another vaccine that was rolled out around the same time, the pneumococcal vaccines, for which diagnostics is much more complicated, diagnosing invasive bacterial disease. it's been much harder to evaluate that vaccine. So it really, the contrast in these two, just to make the point that having basic diagnostics is really the core of analytical epidemiology and program evaluation. And as the diagnostics get moved sort of further out from public health testing or from diagnostic clinics, the point of care or patient tests, like having those kinds of technologies to capture results, to characterize a time series, is going to be critical for us to be able to do this kind of work in the future.
Yeah, I think maybe I'll ask Dr. Andom if he has anything to add as well from his work from a national down to a local level with the healthcare system, and if you might want to add anything about the laboratory system approach, especially since you've been working through the PEPFAR program, which you mentioned. Before having you jump in, though, just a couple of other things perhaps to point out and think back on. One is when it comes to those systems that are needed to be able to more rapidly prevent and detect and respond to outbreaks and public health threats. The WHO member states, so all of the countries that are part of WHO, revised the international health regulations back in 2005 in response to some of those gaps that we saw from the SARS outbreak. And within the international health regulations, that includes those diagnostic systems as well. Now, countries had a lot of challenges, especially the low and middle income countries, with being able to achieve those specific capacities that are outlined in the international health regulations. So then in 2014, countries around the world, including the United States, became part of the Global Health Security Agenda. The Global Health Security Agenda, or GHSA, was sort of a way to outline a roadmap, like a playbook for trying to achieve those capacities that were in, or that are in, the international health regulations. So it was really hard, I think, before then for countries to kind of look at, we have all of these gaps and we have these little resources, so how do we apply those resources to all of these gaps to get from where we are to where we need to be? And the GHSA helped to outline some specific steps and a external evaluation process for experts to go into a country to evaluate it and to say, here's where we think you are in each of your capacities. And here are the things then that you might need to do to achieve that next level of capacity for laboratory systems as well as other necessary systems to achieve the IHR. COVID hit. Now the international health regulations were looked at again, and at the World Health Assembly last year, additional reforms to the international health regulations were voted on and approved to then be put into place. So there's, in addition to what might be happening at the country level, there's also kind of this global architecture that helps to set up a framework for countries to be able to look more objectively at what their strengths are as well as what their gaps are, and help them to then figure out where to apply their resources optimally. So let's see if you'd like to add anything specific from Lesotho.
Yeah, great. So one thing that I want to add is diagnostics is a real challenge in the health system, especially with this COVID-19 pandemic. It was really a challenge to diagnose. Even initially, we were sending samples to South Africa and ICD. And imagine to send sample to cross-border, and sometimes lockdown is there. It's a huge challenge. And until we start our own testing, it took maybe months. And so it now look the result turnaround time, because you don't have informed decision, because you don't have even whether the sample that is sent to cross-border is positive or not. So I think it is a huge challenge in all lower and middle income countries on how to strengthen our capacity to diagnose. One of the solutions could be the point of care testing. I think that mentioned it. It could be easy at different communities or facilities to have the point of care testing, so that the turnaround time is shorter and then easily decision can be made. Thank you.
Thanks so much. Let's go over to my left.
Hi, I'm Sandy Johnson. I'm with the Joseph Corbell School of International Studies at the University of Denver. My question is for Dr. Bastian and Dr. Andon. You've both spoken so eloquently about the links between local and national and international. You've also talked about the importance of partnership, trust, and continuity. And with this broader question of sustainability, you were able to talk about, you see the end coming with a grant, you've made connections, you have partnership, you can harness that to find the next source of funding, the next source of human capital. I work in international development, my students and alumni work there, and for the last few weeks, something I didn't expect to happen happened, and one of the largest funders for development assistance for health basically stopped funding everything. No one saw that coming. Well, maybe we saw it coming, just not as quickly. And I'm wondering if you could share ideas or best practices from your own experience. How do we find emergency gap funding? How do we maintain that trust when some of the critical resources have basically been stopped with very little notice?
Woo.
Yeah.
You want to go for it? No, it's just we're sitting right in the middle of it, so the psychologist is being triggered a little bit. But no, these are real challenges that probably all too many of us in this audience may be navigating as we're sitting here. And it's interesting because we've long been having conversations about broader and more diverse spaces for support for the kind of work that we do with community, but those conversations are getting fast-tracked in the current climate that we're at. What has been encouraging to me is, so a lot of the initial sort of pilot, formative work that helped set the stage for what we're doing now with our community partners was largely sort of NIH and other kind of institutional research dollar funded. But what I've found really encouraging is that the current line of our work that's allowed us to expand to the 4 sites that I talked about, that's allowed us to actually bring in a component that I didn't speak as much because my co-PI kind of leads that arm, but while we've been doing a cultural adaptation of our curriculum with the Haitian immigrant and refugee community, we've in parallel had a cultural adaptation effort for Native American, American Indian population in South California that my co-PI has largely led and oversaw. And for that work, we actually had corporate partner join us. They took interest in kind of the workforce component of this, and they were talking to our institution about other work that we're doing in the maternal health equity space and around training doulas and community health workers to address some of the maternal health disparities in the state of Georgia. And they learned about what we were doing around mental health and were really interested in this idea of a youth-focused lay community health worker force. And so that, to me, was really interesting, like what allowed us to take what we were starting to see in Atlanta to these other 4 sites for the Haitian, to these other 3 sites in the Haitian community, and to branch out to another population with this came out of corporate folks. And so I think this is a time that's challenging us to figure out how to frame and talk to different potential partners about what we're doing and what the impact could be beyond the things that we maybe initially think of. And so my hope, my optimistic hope is that this will push us to be more creative and innovative in how we help folks to see the broader value of the work that we do, because the workforce kind of strategy and that curriculum that we've developed for mental health, we've also used a core component of that for thinking about issues in maternal mental health. And similarly, I think we can use it to think about opioid abuse issues and those kinds of things. And so the challenge will be with us to figure out how to tell that story in a way that compels untraditional and new partners to join us. And the fact that we've been able to get some of the faith communities that we partnered with here to find ways from their own funds and had the community themselves now willing to invest their own funds and participating in some of the things that we brought to the table gives me some confidence that we can also find a basis of support that way. but it's a real challenge that we continue to confront. But this most recent phase of our work and who we were able to bring to the table to support it gives me some encouragement that we can bridge that gap.
Dr. Andom, would you like to comment from Lesotho, or good? Okay, thanks. Let's go to the center. You've been waiting very patiently. Over to you.
Thanks, Nancy. Judy Wasserheit, University of Washington. First of all, thanks to all of you for a really interesting session. This was great. I was particularly interested in the discussion of InsightNet, and for your center and the others that focus on innovation. It seems like if we're really interested in analytics that don't just focus on response, but also on prevention, we need to kind of do a little bit of a turn here and adopt more of a One Health approach. And so my question is, what do you see as the most important directions for innovation in terms of bringing in data and increasing interoperability of data systems, looking at environmental factors, at vectors, at animal, the emergence and reemergence of pathogens in animals, spill over to humans, that whole piece, please.
Great, thanks for your question. It's a big one. So there, I would say across the network, there is a lot of work going on, thinking about not just response in terms of outbreak response, but also early detection, which is of course part of the response, and kind of the One Health component of that is large. I think one area that I find very, very promising is the wastewater surveillance. Right, I mean, we've seen this, how effective it's been for detecting H5 in cattle herds now, but detections in wastewater well before in many areas before detection, in the animals themselves. So I think that is one really promising area. There's a huge amount of work that has to be done to develop the surveillance system, to understand how to do the sampling in a kind of minimally biased way, or ways that detect pathogens, as early as possible, to understand the wastewater shed and the sewage systems, and then how to interpret like the detection results. Right, when you detect a pathogen in wastewater, it's not just positive or negative. Right, there's levels, and interpreting what that means is extremely important for linking, both the animal zoonotic aspects to human health as well. So, I think there's a lot of areas where are ripe for innovation, but wastewater kind of is one that I'm kind of most hopeful about, especially as we kind of move into this era where there might be less, clinical testing performed for all the reasons Dr. Lam has outlined already. Thanks for your question.
Thank you. Let's go over to the far left.
Thanks. Hi, my name is Susan Michael Strasser. I'm at Columbia University, ICAP. We are a large HIV care and treatment partner. I just wanted to say regarding point of care. Point of care essentially is the mainstay of HIV services and HIV scale-up, and I think where there's a will, there's a way. With innovative technology, we now pretty much test for everything related to HIV in the most rural clinics with GeneXpert and other rapid diagnostic tests, integrated HIV syphilis testing, malaria, resistance testing, et cetera, TB LAM testing. So where money is put into it and there's a long-term investment, you really see amazing things happen. The challenge right now is what we're seeing nationally and whether that will wither away, but it is doable, practical, and can be done.
Thank you so much for your comment.
Agreed.
Yeah.
Yes.
Over to the center.
Hi, This is Rajan from India, a public health professional. I have one question to Dr. Bastian. Using young adults in mental health work, in coming from LMICs, there is still a lot of taboo about mental health and how it's managed. How do you handle patient confidentiality when you use these young people in health volunteering and mental health work?
Thank you for your question. It's an important one. I should clarify that up to this point, the work that our young folks have been engaged in carrying out is largely community level, population type interventions and programs. So they're not engaged in sort of one-on-one, more traditional therapeutic kinds of interactions where they encounter as much of what we might be concerned about in the way of sensitive information. They're often doing more sort of educating and sharing with community. However, they are accompanied by licensed professionals for all that they are doing. And as a part of the kind of pipeline process of this, we do, by the end of the program, pair them, for those who are interested in continuing with a trajectory into work in mental health, we pair them with folks that they are able to then sort of shadow or and maybe have the opportunity to do a bit more under the leadership and supervision of those licensed folks. So that I think is an important piece that's allowed us to use them in the way that to engage them in the way that makes the most sense for community. They largely are helping to sort of educate, to resource share, to facilitate connection to services where people are ready and open to that. That's mainly the function that they're serving at this point, but it's an important point.
Thank you. I have one more question, Dr. Lopman.
And we'll do this one very quickly. I just got the sign from the door that we're supposed to be wrapping up.
So I think you very aptly said we are at least a decade away from where the weather modeling is in terms of infectious disease modeling. Are there any lessons learned? We don't really question weather predictions anymore, what we did a couple of decades ago. Is there some roadmap by which we can take out the ambiguity in which disease modeling is suffering as of now, and how we can get to the place where weather modeling is today?
Yeah. It's such a good question and a big one, and since we don't have a lot of time, I'll be brief. Well, I think one thing is harnessing computing power, right? That's one of the reasons that weather forecasting is so much better than it was a decade or 2 decades ago. It's just sheer computing power and the data that goes into that. So those are critical things. The reason, the fundamental reason that infectious disease forecasting is so much harder than weather is, the weather doesn't really care if you put an umbrella up. That doesn't change the forecast. But people change their behavior in response to outbreaks going on around them. They get vaccinated, they isolate, they quarantine, et cetera. So, integrating the human behavior with the biology, natural kind of transmission is what makes disease forecasting so challenging. It's a big topic, and we can continue discussing it over dinner. Thanks.
Thank you so much. I just want to thank all of our panel members for your fabulous presentations and your in-depth discussions, and all of our audience members as well. I think we're all in this global public health and global health world together, and really appreciate the different aspects, the expertise, and the different aspects that you're bringing to bear on ensuring that we are all better protected and prepared for not only the threats that we face today, but those we might face in the future. So thank you so much.